Welcome to the 10-Minute Medic. I'm your host, Dr. Bill Young. One of my former students, who is a now practicing emergency medicine physician in the central Kentucky area, Dr. Caleb Morris, sent in an outstanding suggestion that we cover when VTAC is not VTAC. I'm proud to have a multi-episode series that will cover just that. Thanks so much to Dr. Morris for his awesome suggestion. This condition can be easily mistaken for something more serious, supraventricular tachycardia, or SVT with aberrancy. There's a specific subset of tachycardias where conduction delay in the heart mimics the more dangerous VTAC or ventricular tachycardia. Normally, SVT originates above the ventricles, typically in the atria or the AV node. It's characterized by a fast, regular rhythm, but usually with a narrow QRS. Aberrancy changes this. Here's how. If a bundle branch, which helps to carry the electrical signals to the ventricles, has a delay or blockage, the signal takes longer to reach the part of the heart, widening the QRS complex. This conduction delay occurs often in patients with pre-existing bundle branch blocks or during rapid heart rates where one bundle branch becomes refractory. The result? A wide QRS tachycardia that looks just like VTAC. Now, key differences can help us identify SVT with aberrancy. Unlike VTAC, SVT maintains a regular rhythm without fusion or capture beats. Fusion beats occur when a sinus beat and a ventricular beat happen at the same time, resulting in a hybrid beat with an intermediate QRS morphology. Capture beats occur when a normal sinus beat interrupts a wide complex tachycardia. This happens when the SA node briefly captures the ventricles. Plus, vagal maneuvers or adenosine often slow or terminate the rhythm, something VTAC won't do. Recognizing these clues is crucial for avoiding misdiagnosis and ensuring proper treatment. Aberrancy occurs when the heart's conduction system is slowed or blocked in one of its branches, often mimicking VTAC. A common cause is a pre-existing left or right bundle branch block, which disrupts one of the major pathways to the ventricles. This forces the electrical impulse to take an alternative route, delaying ventricular activation and producing a wide QRS complex. When SVT occurs in these patients, as I said earlier, the rhythm closely resembles VTAC. Another cause is rate-dependent aberrancy, where rapid heart rates prevent the conduction system from fully recovering between beats. One bundle branch remains refractory, leading to abnormal conduction. This frequently occurs during rapid SVT rhythms as the high rate overwhelms the conduction capacity. Triggers for SVT include several mechanisms. Atrioventricular nodal reentrant tachycardia, also known as AVNRT, involves a reentry circuit within the AV node, causing the impulse to loop repeatedly, creating a rapid rhythm. Atrioventricular reentrant tachycardia, AVRT, as seen in Wolff-Parkinson-White syndrome, or WPW, uses an accessory pathway to create a similar route. When aberrancy is present, both rhythms produce wide QRS complexes. Additionally, atrial tachycardia, such as focal or multifocal forms, can result in SVT with aberrancy if conduction delays occur. Contributing factors include structural heart disease, for example, cardiomyopathy or prior infarctions, which disrupt conduction pathways, increasing susceptibility to aberrancy. Electrolyte imbalances such as hypo or hyperkalemia, and medications like antiarrhythmics can also slow conduction, further promoting aberrancy. Now, let's move on to the hemodynamic effects of SVT with aberrancy. These depend heavily on the patient's ventricular rate and overall cardiac reserve. Some patients remain stable, especially if their hearts are otherwise healthy and their rate is only mildly elevated. For these individuals, the symptoms may be limited to mild tachycardia and palpitations. However, in patients with reduced cardiac reserve, perhaps due to structural heart disease, previous MI, or heart failure, the rapid rate can push their cardiovascular system beyond its limits. When this happens, they may develop hypotension, where blood pressure drops significantly. This is often due to the lack of time for the ventricles to fill properly before contracting, leading to decreased stroke volume and cardiac output. This is another area why the understanding of the concept of preload is so very important. With hypotension comes a cascade of additional symptoms. Reduced perfusion to the brain may cause altered mentation, where patients become confused, disoriented, or lethargic. In extreme cases, this can progress to unresponsiveness, a sign of critical instability. The degree of hemodynamic compromise also depends on the ventricular rate. When the heart is beating exceptionally fast, even a healthy heart can struggle to maintain adequate output. But for patients with existing conditions, the margin for error is much smaller. Diagnosing SVT with aberrancy can be tricky because it mimics VTAC on an EKG. But there are some key clues that can help us to make the distinction. So let's take a look at some of these important diagnostic tools. The first place to look is at the EKG. The hallmark of SVT with aberrancy is a wide QRS complex, typically greater than 120 milliseconds. This widened appearance is due to delayed conduction through the ventricles, again, often caused by a bundle branch block. Unlike narrow QRS tachycardias, the wide complex can make it hard to immediately distinguish SVT from VTAC. Another critical EKG feature is the regularity of the R-to-R intervals. In SVT with aberrancy, the rhythm is typically regular with evenly spaced QRS complexes. This contrasts with irregular rhythms such as atrial fibrillation with aberrancy, where R-to-R intervals vary like crazy. Regularity is an important clue when evaluating wide complex tachycardias. Let's take a look at P waves. In some cases of SVT with aberrancy, particularly AVRT, P waves may be obscured by the rapid rate or even appear retrograde, meaning that they are inverted and follow the QRS complex rather than precede it. These P waves can provide further evidence that the rhythm originates above the ventricles. One of the defining features of ventricular tachycardia is the presence of a caption or a fusion beat. Again, these are individual beats or complexes that result from a simultaneous activation of the ventricles by both a supraventricular impulse as well as a ventricular impulse. Their absence in SVT with aberrancy strongly supports a supraventricular origin. Carefully examining the EKG for these subtle beats can make all the difference in diagnosis. Our next step is to get the patient's history. A prior diagnosis of a bundle branch block or a history of intermittent aberrant conduction is a major clue. Patients with these conditions are more likely to present with SVT that has a wide QRS than VTAC. It's also important to ask about episodes of rapid heart rate or previous treatment for SVT, such as atrioventricular nodal reentrant tachycardia, or as I said earlier, AVNRT. A history of these rhythms increases the likelihood that the current presentation is SVT with aberrancy. Finally, the response to vagal maneuvers or adenosine can provide diagnostic clarity. Vagal maneuvers like carotid sinus massage or Valsalva maneuver and medications such as adenosine work by temporarily blocking conduction through the AV node. In SVT with aberrancy, this can slow the rhythm or terminate it entirely. If the wide complex rhythm responds to these interventions, it is almost certainly SVT. On the other hand, a lack of response suggests a ventricular origin such as ventricular tachycardia. This distinction is critical because the treatments for SVT and VTAC differ significantly, and misdiagnosis could lead to inappropriate and potentially harmful interventions. By carefully analyzing the EKG, considering the patient's history, and observing the response to diagnostic maneuvers, we can confidently differentiate SVT with aberrancy from other wide complex tachycardias, ensuring that the patient receives the right care at the right time. Treating SVT with aberrancy requires a careful and methodical approach to ensure appropriate care. Initial assessment begins by determining the patient's hemodynamic stability. Are they stable with adequate blood pressure and mental status, or are they unstable with signs of hypotension, altered mentation, or severe distress? Stability dictates the urgency and type of intervention. Simultaneously review the patient's history and EKG findings for clues suggesting aberrancy rather than a ventricular origin. For hemodynamically stable patients, treatment starts with non-pharmacologic therapies. Simple vagal maneuvers like the Valsalva maneuver or carotid massage can often slow or terminate the rhythm by increasing vagal tone and reducing AV node conduction. If vagal maneuvers fail, move to pharmacologic therapy, starting with adenosine, a first-line drug that transiently blocks AV node conduction. In refractory cases, beta blockers or calcium channel blockers can be used to control the rhythm. For unstable patients, immediate synchronized cardioversion is the treatment of choice to restore a normal rhythm. Concurrently, identify and correct any reversible causes, such as electrolytes abnormalities or drug toxicity. For recurrent episodes, long-term management involves identifying causes through electrophysiological studies and, if necessary, performing catheter ablation for a definitive cure. Preventative medicines such as beta blockers or antiarrhythmics may also be prescribed. So some clinical pearls to take with you are, first, always correlate EKG findings with your clinical presentation and history. Another way of putting that is treat your patient, not to monitor. Vagal maneuvers and adenosine are both diagnostic and therapeutic in SVT. And number 3, persistent wide complex tachycardia that does not respond to AV nodal blocking agents should raise suspicion for VTAC. So as we close this out, SVT with aberrancy can mimic VTAC, but requires specific diagnostic tools to differentiate. Early recognition and treatment improves outcomes and prevents complications. Take the patient's history, the EKG interpretation, and therapeutic response all together are essential for effective management. In our next episode, we'll take a look at another VTAC imposter, hyperkalemia as a ventricular tachycardia mimic. That podcast will be posted about a week from today. I hope you'll join me for it. Thanks again for tuning in.